Hey everyone, I think we can start now. So thanks for making the effort to come today. Over the next hour, we're going to have three very interesting presentations for people to present to you. Firstly, we've got Krista Walter from the University of Michigan, and she's going to be talking about the use of SGLT2 inhibitors in thoracic transplant and giving you a pre and post-transplant perspective. The second presentation will be Rick Cosgrove, and he's going to be talking about tacrolimus TDM, giving an overview of the genomics, boosters, and formulations. And the third presentation today is going to be from Spain, giving you thoracic transplant experience with that. So the way that the session will work today is that each presentation will be approximately 15 minutes, and there'll be 5 minutes for questions at the end. If there's actually a chat area for you to actually post any questions. If we have time at the end of the actual presentation, we'll do that. Otherwise, we'll move on to the next presentation. So we'll start with Krista talking about the SGLT2 inhibitors pre and post transplant. Thank you.
Thanks, Steve. Let me just share my screen here. All right, can you guys see my slides okay?
Yep.
All right, so I'm going to be talking about the use of SGLT2 inhibitors, both pre and post transplant, which is a very interesting topic right now. I don't have anything to disclose today, and I'll start off by just reviewing some of the benefits and risks of using these agents in our thoracic transplant population, and then we will conclude this talk by describing the current practices pertaining to the use of SGLT2 inhibitors post-thoracic transplant. So as I'm sure all of you know, SGLT2 inhibitors have really become a hallmark of therapy for patients with type 2 diabetes, as well as heart failure and chronic kidney disease. Not only have they been shown to reduce cardiovascular mortality, but they've also been found to reduce the rate of CKD progression and hospitalizations in these certain populations. So as a result of these several landmark trials that I have listed below, recent guidelines for these disease states have all incorporated SGLT2 inhibitors for consideration in the management of these patients. However, given that most of these trials had excluded patients who were immunosuppressed, this leaves sort of a gray area for our thoracic transplant population. Overall, looking at some of the risks of SGLT2 inhibitors and the adverse event profile has really led to hesitancy using this class of drugs in solid organ transplant recipients who are immunosuppressed. So notable adverse effects include acute kidney injury, volume depletion, and hypotension. Cases of ketoacidosis, including euglycemic diabetic ketoacidosis, have also been reported. And then for our transplant patients, a lot of people are concerned about the risk of genitourinary infections, lower limb amputations, necrotizing fasciitis, and bone fractures that have been rarely reported. So thinking about using these drugs in both our pre and post-transplant considerations, I think it's really important to consider not only the benefits they could get, but also these risks that I just mentioned. So on the heart transplant candidate side, there are several patients that may actually be evaluated for transplant who are on SGLT2 inhibitors as part of their GDMT for their heart failure. So I really want to point out the perioperative risk that's been noted with SGLT2 inhibitors in this population. So I want to bring your attention to a case report of a 55-year-old male who was admitted for acute decompensated heart failure secondary to non-ischemic cardiomyopathy. He also had a history of prediabetes. The patient underwent successful heart transplant. However, he was maintained on dapagliflozin up until the time of transplant as part of his heart failure regimen. 2 hours postoperatively, he developed an anion-gap metabolic acidosis with subsequent shock and acute kidney injury. 4 hours postoperatively, the team started an insulin infusion and the anion-gap metabolic acidosis had improved, and ultimately the patient clinically improved was found to have no rejection on biopsy and normal graft function. So something really interesting about this case, as you can see in table 1 here, is the patient did develop this anion gap metabolic acidosis. However, his blood glucose values were all well less than 250, and he did not have any urine ketones. Serum ketones weren't checked in this case, and a beta hydroxybutyrate wasn't checked until 10 hours after the insulin infusion was initiated. So the authors actually had concluded that this case was a case of euglycemic ketoacidosis secondary to SGLT2 inhibitor use until the time of transplant. Some of the risk factors for euglycemic ketoacidosis include any metabolically stressful events, such as surgery like a heart transplant, and in the case of this patient, periods of prolonged fasting. Other risk factors for this that the authors identified include high-dose steroids, which can further increase insulin resistance. The patient also had a recent dose increase of the SGLT2 inhibitor 14 days prior to transplant, and then the history of prediabetes was noted as another risk factor. So looking at the mechanism of ketoacidosis with SGLT2 inhibitors, so mechanistically, we know SGLT2 inhibitors increase urinary glucose excretion. As a result, this actually will decrease plasma blood glucose levels, decrease insulin secretion, and increase glucagon secretion. When you combine this with surgical stressors such as a heart transplant that increases counter-regulatory hormones and a state of preoperative fasting, you get the perfect storm for ketoacidosis because you get increase in free fatty acids and increase in ketone bodies that can lead to euglycemic DKA. It's important to note that this can occur at blood sugar levels less than 200, and urinary ketones may not actually always be present because SGLT2 inhibitors mechanistically increase ketone body reabsorption. Furthermore, the increases in urinary glucose excretion that are seen with SGLT2 inhibitors can persist for several days even after the drug is discontinued. So where this comes to play in our heart transplant population, and maybe our lungs if someone were to be on it prior to listing, is that prescribing information actually recommends to hold these agents for 3 to 4 days prior to surgery to minimize this risk. So it's really important to evaluate for SGLT2 inhibitor use at the time of listing. One could consider discontinuing the agent at that time or at the time of status changes and the patient's listing status changes. If it is continued until the time of transplant, monitoring very closely postoperatively for ketoacidosis is important. All right, so next we'll move on to some post-transplant considerations. So in our heart and lung transplant recipients, there are many patients who have comorbidities such as type 2 diabetes or post-transplant diabetes, heart failure, and CKD that can develop post-transplant. So many of our patients may have a strong indication for using these drugs. However, unfortunately, there's not a lot of data in our thoracic transplant population. Most of the data is in the kidney transplant population. And for the purposes of this talk, I won't go into that data, but I did want to point your attention to a prospective study that was actually done looking at empagliflozin compared to placebo in kidney transplant recipients with post-transplant diabetes. And they had concluded that this appeared safe and improved glycemic control in this specific population. For the thoracic side, the data, like I said, is very limited. There's no published data that I could find in the lung transplant population. However, there were 3 retrospective studies that have been published looking at SGLT2 inhibitors in the heart transplant population. The most recent one that was published was a retrospective study done in 2021, where heart transplant recipients with type 2 diabetes who were on an SGLT2 inhibitor or a GLP-1 receptor agonist were analyzed. All these patients were about 5.7 years post-transplant. And what they found was that the combination of these was very effective in terms of reducing glycemic control. They also saw a significant reduction in weight. And then notably, I want to point out the safety events, which include 4 drug discontinuations due to cost and tolerability. But the authors did note that all 4 of these cases were able to then restart the SGLT2 inhibitor at a later time. They did not see any cases of ketoacidosis or genitourinary infections in this report. A similar single center retrospective study again looked at heart transplant patients who were about 5 years post-transplant. And in this study, they specifically looked at empagliflozin in patients with post-transplant diabetes or type 2 diabetes. In terms of efficacy, they actually didn't see a change in A1C, but they did see a significant decrease in diuretic dose and body weight. And then from a safety perspective, they had 3 reports out of the 22 patients who are on an SGLT2 inhibitor, including dizziness, 1 report of AKI, and then 1 report of exacerbation of urinary symptoms. They did not see any genitourinary infections in their SGLT2 inhibitor cohort, but they did see 9 UTIs in their control cohort. And then similar results were published in 2017 by the same group. Again, they looked at empagliflozin compared to controls in heart transplant recipients with type 2 diabetes. And we saw same efficacy parameters, a decrease in body weight, decrease in oral diuretic dose, as well as a decrease in blood pressure this time. And again, this cohort, only 2 adverse events were noted, 1 including dizziness and then 1 of polyuria. So overall, this data from the heart transplant, although very limited, suggests safety of these agents when used at a median of 5 years post-transplant. So if we are going to use these post-transplant, I think there's a few things to really consider. One is the timing of initiation. When could these be considered to be initiated? So some things to think about include the stability of their graft function, as well as the stability of their immunosuppressive levels, and then their overall immunosuppression burden at that time. Renal function and volume status is very important, especially given that SGLT2 inhibitors can have a little bit of a diuretic effect. And then I would strongly consider any recent history of any genitourinary infections or pre-existing lower urinary conditions prior to prescribing this agent. And then sick day protocols and perioperative protocols are also something that's really important to educate patients on. So one could consider in times of acute illness, instructing the patient to hold their SGLT2 inhibitor and let the team know immediately if they're not feeling well to minimize that risk of ketoacidosis in these states. So given the lack of data in the transplant population overall, the pharmacists at the University of Michigan had actually recently sent out a survey to 3 different transplant organizations. ISHLT was one of them. So some of you may have actually filled this survey out. But we were really trying to understand practices pertaining to the use of SGLT2 inhibitors post-transplant. So we sent out a 10-item electronic survey this past fall. And I'm going to go through the results here, focusing on the results that we found from the thoracic transplant population. So overall, for this survey that we sent out, we had a total of 66 responses. 10 of those responses were from pharmacists caring for lung transplant recipients, and 14 were from pharmacists caring for heart transplant recipients. So although we did have a pretty low response rate for this survey, we did have some from the thoracic population respond. So a few of the questions that we asked is, first, we wanted to identify what the transplant center's approach was to using SGLT2 inhibitors post-transplant. We were curious if certain centers just avoided them at all costs, or certain centers had protocols where they had to meet certain restriction criteria to use these agents. What we found overall is there wasn't really a consistent approach amongst transplant centers, and using these agents was really at the discretion of the individual prescriber. There was about 25% of people who said that their center used in restricted patients only. And some common restriction criteria we saw was a specific time post-transplant or a specific EGFR post-transplant. Some only considered in patients not requiring insulin for hyperglycemia control. Some only considered in patients without any infection concerns. And then some strongly considered the immunosuppression burden at that time. We then surveyed to see when the earliest time pharmacists would feel comfortable initiating an SGLT2 inhibitor post-thoracic transplant. And you can see most people felt comfortable 1 to 6 months post-transplant. There wasn't very many within the first month post-transplant that would start it. And then I do want to point out only 4% of the respondents from the thoracic group said they did not feel comfortable initiating these agents post-transplant. Looking at the most common indications for using SGLT2 inhibitors in this population, by and large, post-transplant diabetes or hyperglycemia was the most common reason pharmacists would consider using this. However, we did see a good chunk of patients for the other indications we know SGLT2 inhibitors have benefit in, such as heart failure and CKD progression. We also surveyed folks who avoided using these agents post-transplant because we wanted to know why. And again, by and large, the most common concern or reason to avoid using these agents post-transplant was the infection risk. And then following that was the limited data in the transplant population. I thought it was interesting that medication access and the cost to patient overall were a little bit lower on this list, but you can see there's still something that the pharmacists are thinking about. Looking at which agent the pharmacist preferred to use and then what were the major factors that influenced the selection of this, there wasn't really a preferred agent. Most people said that depended on patient-specific factors. For those that did have a preference, either empagliflozin or dapagliflozin was the preferred agent. And then when looking at what was the major factor that influenced the agent that was used, for the most part, it was insurance followed by provider preference. And then looking at if people were following the package insert recommendations for holding SGLT2 inhibitors before upcoming surgery, most of the pharmacists in this cohort responded yes, they recommend to hold them. So overall, we found in this small survey that the majority of pharmacists caring for the thoracic transplant recipients felt comfortable using an SGLT2 inhibitor at 1 to 6 months post-transplant, and commonly it was used for diabetes or hyperglycemia. The major concerns or reason to avoid use was either infection or the limited data in the transplant population. And then insurance really played a big role in determining which agent was actually prescribed in this population. So that's all I have. Thank you so much for your time.
Awesome. Thank you, Dr. Walter. Great topic. I think it's really relevant. I think we might have time for one, possibly two questions. If anyone has a question for Dr. Walter today, please feel free to speak up or put it in the chat if you can. All right. Well, seeing none, I think just to keep us honest to our schedule, we can go ahead and move on to our next session. Oh, Steve, did you have a?
No, I didn't have any questions. So
Okay.
yeah, if you want to introduce the next speaker.
Perfect. Yeah, to keep us on our schedule, we'll go ahead and move on to the next session. If you do think of a question, you can go ahead and pop it in the chat. If we have time at the end of the session, we can move on to that. But up next is Dr. Cosgrove, who will be presenting tacrolimus, TDM, genomics, boosters, and formulations. So thank you, Dr. Cosgrove.
Thanks very much. Pleasure to be with you today. I'll be playing my slides, keep me on track. Let me know if there's any issues. Welcome everyone to this discussion of tacrolimus, the macrolide compound produced by a fungus in the soils of Mount Tsukuba in Japan. There is little debate regarding the important role the calcineurin inhibitors have played in the success of transplant medicine over the past 40 years, and yet we still have a ways to go to fully understand their characteristics that allow for maintaining patients in a therapeutic range. Harkening back to our roots in pharmacokinetics, perhaps a clinical pharmacist's skill can be a benefit in predicting the appropriate dosing for each patient. For instance, if we consider a patient as 80 kilogram, then we can assume the volume of distribution would be 120 liters. If we give the patient an oral dose of tacrolimus 3 milligram and assume 20% absorption, 600 micrograms should be delivered into the bloodstream, resulting in a drug concentration increase of 5 nanogram per milliliter. Comparing that to the patient's actual measured response can help answer questions about what is happening pharmacokinetically. Does a patient absorb well and have decent clearance? Or is there only moderate absorption with a long half-life, as opposed to good absorption with poor metabolism and the risk of drug accumulation and therefore toxicity? Well, there are certainly a multitude of factors that explain these different responses pharmacokinetically, and it's fairly different from what our predecessors in clinical pharmacy dealt with, say, aminoglycosides that have a very predictable pharmacokinetic response. These orally absorbed, hepatically metabolized drugs will rely heavily on different issues regarding absorption, distribution, metabolism, for which we know 3A5 is important, and elimination. The pharmacogenomic modeling can be important and very interesting, but the proof in the pharmacokinetic pudding is the initial level evaluation. Numerous suggestions about when to measure levels have been suggested. Should we measure trough levels, 2-hour post-dose levels? Raguet and colleagues did extensive evaluations on multiple point drug levels to compare them and correlate them with goal area under the curve. Amongst their 2-point level analyses and models, the 2-hour and 6-hour levels provided the best relation to area under the curve. Once we calculate the elimination constant with the 2 levels, extrapolating to any point along the curve is possible, and therefore we can make an estimation of the area under the curve. If you find you're having trouble achieving adequate levels, then different strategies can be employed to ensure better absorption, say, from giving the drug on an empty stomach, giving it sublingually even, can avoid that enterohepatic circulation and get significant absorption sometimes, which is quite variable depending on the technique. First pass metabolism may keep peak concentrations low due to the P-glycoproteins and CYP3A enzymes, and numerous agents obviously inhibit those. But also keeping an eye out for agents which induce these enzymes and inadvertently keep the concentrations low, of which steroid is often one of these culprits, which is unavoidable, but something to keep in mind as we start to taper off these drugs. In the gut microbiome and its metabolism of tacrolimus will continue to be an area of study. Numerous agents obviously inhibit these different enzymes, and there might be subtle differences between the potency of inhibition of a P-glycoprotein versus a CYP3A enzyme inhibition. We all likely have seen the effect of an azole, of which some are more potent than others. Ketoconazole, voriconazole have extremely potent inhibition of the P-glycoprotein and likely contribute to initial strong concentrations and strong peak concentrations. Whereas more mild effects can occur from the calcium channel blockers, where diltiazem, verapamil may be more likely to inhibit 3A4 or 3A5 and cause a longer half-life. In general, it feels somewhat unnatural to consider adding a drug simply to inhibit another one. But perhaps we should consider that there may be serendipitous benefit from doing this. Here we see a number of reports adding ketoconazole to tacrolimus, primarily really to reduce drug cost in some of these foreign countries in renal transplant patients. They used 100 milligram ketoconazole and decreased the tacrolimus dose by 50%. One group found somewhat more rejection in the ketoconazole group. However, it was a retrospective analysis. Interestingly, graft function of the kidneys all showed improvement, and in some actually had improved graft function compared to the non-ketoconazole comparator. This concept that the amount of metabolism itself may be rather important is interesting. In abdominal transplants, it's shown that fast metabolizers have more rejection, which goes to follow since the levels might run low. However, it's also noted that fast metabolizers may be at increased issues for calcineurin inhibitor induced renal toxicity. A simple calculation has been proposed to quantify this effect. A CD ratio, which divides tacrolimus trough to the steady state tacrolimus dose per day, and suggests that a CD ratio under 1.0 might imply the patient is a fast metabolizer. Further investigation should be undertaken to evaluate whether this logical scenario exists that less total parent drug and less total potentially toxic metabolite around can improve the adverse effect profile of these drugs and improve outcomes. Further understanding the nature of these drugs may help us with how to manage these patients. When we look at how a tacrolimus assay is prepared, we realize that tacrolimus is heavily bound to red blood cells, and it must be dissociated from the cells in order to be measured, whether it be mass spectrometry or luminescent immunoassay. In fact, the proportion of tacrolimus that is bound to red blood cells is approximately 85%, whereas 14% is bound to albumin and plasma proteins. Only 0.5% or so is bound to T cells and lymphocytes, and even a smaller fraction may exist as unbound fraction. It's this unbound fraction that makes some in the field consider the possibility that this characteristic may form the basis of some nephrotoxic and neurotoxic effects. The molecular weight of tacrolimus is 800 Daltons. Cyclosporin is 1200. The glomerulus allows passage of molecules under 30,000 Daltons. When bound to a red blood cell, which is 95,000 Daltons, only unbound fraction flows through into the tubules. Thus, it's dependent on the concentration of unbound tacrolimus as to how much gets into the tubule. Regarding neurotoxicity, The blood-brain barrier is obviously different and more restrictive in that only molecules under 500 Daltons allow passage into the cerebrum, which poses the possibility why tacrolimus may be more neurotoxic than cyclosporin. Sigma and colleagues in the Netherlands further evaluated this concept of unbound tacrolimus and found that amongst similar whole blood concentrations, here on the y-axis, of 20 nanogram per milliliter, you can have wide variation in unbound tacrolimus level, up to 10-fold. In fact, they propose reporting tacrolimus in hematocrit adjusted terms. The more red blood cells around, the less unbound tacrolimus at the same total tacro level. Therefore, at lower hematocrits, you'll have more potential for unbound tacrolimus concentration and potentially more toxicity. Since there have been fatalities even by giving calcineurin inhibitor in injectable form in too large a quantity and too quickly, it's obviously recommended to consider giving or following the package insert recommendation to give tacrolimus or cyclosporin only as a continuous infusion. And yet there are examples of reports lately that suggest speeding up the infusion and even using the word bolus in the title, which is concerning. By giving it continuous infusion, you allow the unbound tacrolimus at least the 2 minutes it takes to achieve binding to all the different cells and proteins that prevent the unbound form from causing toxicity. It is also possible that sublingual dosing can have similar effects to injectable. The sublingual absorption of tacrolimus avoids the first pass metabolism and exists in an unbound state. Here are two cases of immediately post-op heart transplants that were initiated on 2 milligram sublingual doses of tacrolimus twice a day. The first 49-year-old patient by day 6 experienced significant kidney injury and had to be held after increasing the tacrolimus sublingual dose from 2 milligram to 4 milligram BID. A 64-year-old heart transplant patient experienced exaggerated absorption with tacrolimus levels of 11.4 on post-op day 2 and experienced a generalized seizure. For these reasons, it may be wise to use a rule of thumb of never using more than 2 milligrams tacrolimus sublingually. So the challenge remains with calcineurin inhibitors, but through further understanding of the patient responses to the CNI behavior and advances in the care of these patients, we hope to attain better outcomes. Thank you so much. Look forward to the questions, comments, and potentially collaborations.
All right, awesome. Thank you, Dr. Cosgrove. I think we have a couple minutes, so if there's any questions specifically to Dr. Cosgrove, please put them in the chat or speak up. All right. Again, if you have anything that pops up, I see we got one from the previous talk, please put it in the chat and hopefully we'll have some time at the end to answer those questions. So thank you again, Dr. Cosgrove. Our final speaker today is Dr. Ana Sangrodor, who will be presenting Pharmacists Around the World, the Spanish Experience.
Good afternoon. Thank you very much for the ISHLT for this opportunity to share with you our experience as transplant pharmacist in Spain. I'm going to share with you my presentation, but in fact, Ed Horn is going to do it for me. And thank you very much, Horn, Ed. Good afternoon. Many thanks to the ISHLT Pharmacy Council for allowing transplant pharmacists in Spain to show you the activities we carry out and the future plans we have. I am Ana Sangrador. I am a hospital pharmacist in Hospital Marqués de Valdecilla in Santander, Spain. In Spain, there were pharmacists working in the transplant area for a long time, but we didn't know each other. It was thanks to a scholarship in Harfield Hospital, London, from the SEF, Spanish Society of Hospital Pharmacists, with ISHLTv as a tutor in 2017, thanks to the Stockman masterclasses and the subsequent opportunity of meeting with ISHLTv and Patricia Jean at the Spanish Hospital Pharmacy National Congress in Palma de Mallorca in November 2018, when we met and began to work together. This same day, we created a networking group for collaborate between colleagues in a field that requires high specialization. For this reason, within the SEF, a group of pharmacists motivated by this topic created a specific work group of transplant pharmacists 3 years ago. Pharmatransplant is the name in English and Pharmatrasplante in Spanish. We use WhatsApp group and email chain to share news, training, helping clinical practice, etc. Our objective as a group is promote the role of the hospital pharmacist in the area of SOT in Spain as an essential member of the MDT, with the aim to adding value to the comprehensive care process of the transplant patients. We are 10 of us in the coordinator group and 42 members, increasing as collaborators, and we have a scholar and a resident in the group with different roles. But what do we promote as transplant pharmacist group? First of all, we promote that all transplant patients have proper information about medicines and healthy living habits provided by pharmacists during the hospital stay after the transplant. We provide informative sessions on medications, how to take them, what they are for, how to organize them well at home, the importance of adherence, especially immunosuppressants, and also on healthy lifestyle habits. We carry out a pre-session survey to find out what they know before the information and deliver an informative book prepared for the occasion. All this is done in coordination with the MDT, doctors, nurses, endocrine, rehabilitation, nutritionists, surgeons, etc. Upon discharge, we deliver a planning with all the medications that the patient must take, the amounts and times, and also medication for a week. We promote the coordination between care levels too, with the pharmacist or the patient's referral hospital, sending them the planning and commenting on any topic of interest during hospital stay. We coordinate with the patient's pharmacy to inform them of the discharge and send them the planning. In the near future, this will be happening through Spain. Also, we promote care continuity, because we make a phone call 3 weeks after discharge to find out how everything has gone, what problems they have had, and also to carry out the post-session survey. In the outpatient clinic, we attend to those patients that the doctors, pulmonologists in my case, believe have more difficulties in complying with the treatment. We carry out a survey of adherence and therapeutic complexity. Soon, through Spain with Cantabria, my region, as one of the pilot regions, a joint project of the CEF and the General Council of Pharmacists in Spain called Juntos, together in English, for the continuity of pharmaceutical care between care levels, hospital pharmacy and community pharmacy, because it's in the community pharmacy where patients go to pick up most of their medication through their lives. We want the community pharmacists to be well trained in transplantation so that they can care for transplant patients in the best possible way and improve adherence to the treatment. And we promote the conduct of adherence surveys. Adherence in transplantation is variable over time. It's higher closer to the transplant and decreases over time. According to various studies, non-adherence can affect around 25 to 50% of patients. So it's very important that we evaluate it to try to ensure maximum adherence through the patient's life. To evaluate it, we use the SMAC questionnaire, validated for transplant patients. It's a very short questionnaire, 6 questions and less than a minute to complete, on medication taking habits that evaluate different aspects related to compliance, oversights, routine, adverse effects, and quantification of omissions. And we promote assessment of therapeutic complexity. The recipients of SOT are very vulnerable patients with numerous associated comorbidities and who receive highly complex treatments. The high therapeutic complexity of these patients is due to 3 reasons. The derivative of the treatment itself that they must receive at the transplant, the increase in patient survival leads to the appearance of comorbidities derived from age itself. And third, older patients who already have multiple comorbidities are increasingly being transplanted. Therefore, to the medication they take due to the transplant, more medications must be added to treat these comorbidities derived from these treatments, and those that appear with age: hypertension, diabetes, dyslipidemia, renal failure, osteoporosis, etc. The consequences of this high therapeutic complexity are serious, since they can cause less adherence, increased interactions, side effects, and an increased risk of visits to the emergency room, hospitalization, and mortality. For these reasons, the PharmaTransplant Working Group believes that it's necessary to quantify the morbidity and therapeutic complexity of patients undergoing SOT with objective measures, and for this, we are going to carry out a national clinical trial. It's the Complextos trial, whose primary objective is quantitatively measure multimorbidity, 2 or more comorbidities, and therapeutic complexity by counting the number of drugs and the patient-level medication regime complexity index, an Spanish version calculator, of adult and pediatric SOT patients nationwide. As secondary objectives are identify predictors of a higher total score, know the beliefs of patients about their therapeutic regime, and design interdisciplinary strategies to reduce post-transplant therapeutic complexity. We promote the digital health too. More and more mobile health is prevailing in patient care. Within the SEF, we want to give it a boost, especially with transplant patients. This is a EMMA Salud platform, which has already been used in Sant Pau Hospital in Barcelona as mHeart platform and in Gregorio Marañón Hospital in Madrid. It's a platform with a version for professionals, doctors, pharmacists, and nurses, and for patients too. For example, in the version for patients, via PC or app, they can see their treatment, carry out the self-controls that have been decided and enter the data, record any side effects that appear, view advice on medications and healthy lifestyle habits, and communicate by messaging with the corresponding professional. To find out the feasibility, satisfaction and experience during using the mobile health in the comprehensive management of ISHLTv patients, we are going to carry out a national clinical trial with this objective. Also, to find out the degree of satisfaction of the users involved through a specific satisfaction service, to include possible improvements in routine clinical practice or in the app. And we promote pharmacist training. As one of the pharmacist group main objective is to increase the training of the hospital pharmacists in the field of SOT and also spread our work so that more hospital pharmacists integrate in our community. We organize courses and attend others that have been taking place for some time in Valencia and Hospital La Fe, for example. Through our web page and the social media, we disseminate the activities that we carry out to disseminate knowledge among pharmacists in the SOT area. For example, pharmacotherapeutic bulletins, literature reviews, pharma pearls, newspapers, congress, courses, etc. For example, pharmacotherapeutic bulletins are for monthly frequency, are review of a topic of interest in SOT, and the last ones have been immunosuppressive phytotherapeutic preparations interactions, dyslipidemia in transplantation, hypomagnesemia after transplantation, and use of anti-cytomegalovirus IgG, and for example for post-transplant diabetes is the next one. The literature reviews are by monthly periodicity, are a review of the publications of the last 2 months related to SOT. And pharma pearls, which are by weekly periodicity, are a presentation of a clinical case in Twitter and Instagram with 4 possible solutions, where the colleagues vote on the chosen answer. After 24 hours, the solution and a brief explanation of the case are published. And finally, we promote specialization. We need to increase our degree of specialization and have it certified. In Spain, there is no specific training for pharmacists in the area of transplantation. For this reason, we must take advantage of every opportunity to train ourselves. For example, in UK, SOFA master classes and the ISHLT community webinars, the ISHLT in Spanish webinars, and DPS certification, specific transplant congresses and courses, etc. And last but not least, we need disseminate our rules. To do this, in February 2022, we published the Transplant Pharmacist Activities Guide in the ISHLTv in Spain, in order to disseminate the functions that we carry out and those that we can potentially carry out based on what colleagues in other countries as UK, Ireland or America already do, and on the available bibliography, so that the managers of the hospital pharmacies, managers of hospitals, managers of their regional health services are aware of them and aware of the benefits provided by the integration of hospital pharmacists in transplant entities. This guide includes the activities that we can carry out from the pre-transplant phase, during admission and post-transplant phase in outpatient clinics and in readmissions to hospital. And for today, that's all. Thank you very much for your attention. I'm ready to answer your questions. Thank you very much.
Thanks very much, Anna. It looks like we have got some questions on the board here, so we can start working our way through them. Firstly, to Krista's talk on the SGLT2 inhibitors. I don't think anyone's answered that question, but Krista, have you seen any? There's a question here about electrolyte disturbances with the SGLT2 inhibitors, particularly hyperkalemia. Have you seen that at all?
Yeah, that's a good question. I mean, theoretically, it's a concern because the mechanism of SGLT2 is when you get the urinary glucose excretion and the osmotic diuresis, you could increase aldosterone production, which would increase K. Like the big trials, not in transplant patients, of DAPA and empagliflozin didn't really see a difference in serious hyperkalemia, but I have seen it reported with higher doses of canagliflozin. It's kind of hard to interpret the results though, because a lot of these people are on RAS inhibition with like ACE inhibitors or ARBs. So it is a little bit conflicting. And then you also can see their diuretic dose go down too. So they could get less K wasting from that. So it's hard to see, but definitely, yeah, monitoring electrolytes would be good. But I haven't seen too many cases myself of severe hyperkalemia with them.
I guess I've got a question as well. So from the results of your survey, from what you found from the different centres, did you make any immediate changes to your practice from what you found, or what were your insights into the results?
Well, unfortunately, we didn't get as many responses as we had wanted, but it was interesting to see. I personally haven't changed anything to my practice quite yet. But this has actually come up recently from some of the physicians at our institution with some of the newer data that's come out with SGLT2 inhibitors and CKD. So there has been some interest in using it more for that indication, especially since lots of our transplant patients get the CKD post-transplant, but I personally haven't made any change. I think it's just heightened awareness a little bit amongst our pharmacy group and other physicians. Mm-hmm.
Thank you. We'll probably move on to the next questions regarding Rick's talk on TACRO-TDM. Thanks, Patricia, for clarifying your question, because I was thinking, have I missed something? So I guess the first one from Patricia asking about the microbiome to improve TACRO levels. Have you got any information on that, Rick?
Sure. I'm not aware of anyone who's actually tried to alter the microbiome in the gut. There's been good work from the Columbia group on measuring what are the components of the microbiome and which bacteria in particular may have the metabolic effects on the TACRO, but not so much as I'm aware. Is there someone who's actually tried to modify? The critical care folks have data showing the sheer amount of microbiome may affect outcomes, and those that have wiped out their microbiome may have worse outcomes in the ICU, which is kind of interesting.
I guess we'll move on to the next question. Same for Rick as well, about sublingual tacrolimus. How would you recommend dealing with patients where the dose should be limited to 2 milligram? I'm not actually aware, like I know at our institution, we don't limit it to 2 milligram. We've had issues with it, but do you have any recommendations for the group?
Right. Yeah. This will be interesting for us all to keep an eye out for. And do you see some adverse effects from using too much too quickly? Is it a patient who has those level spikes after too big a dose? It seems like the ones that really are harshly affected have the level spike, whether it be sublingual or oral. But if it's in the unbound form, it potentially has the effect of greater toxicity. If it only takes 2 minutes to associate with a protein or a cell, that shouldn't be too long. But if your cardiac output is 5 liters per minute, that allows for a couple of laps around the body. So if you need, and many will, higher doses than 2 milligram BID, what we'll do is 2 milligram Q6 or even 2 milligram Q4 sublingually.
And the final question for you, Rick, is about TDM of intravenous tacrolimus. Do you have any recommendations for the group on that, or do you just do TDM on the oral treatment?
Well, that is an issue for us, isn't it? Not as far as I'm aware, is there data on an AUC based on the continuous infusion, which will obviously have a different calculation and a different AUC. We can't base our dosing necessarily on a trough level goal when you're measuring a continuous IV. So somebody out there should potentially consider that. And as a pharmacokinetics nerd, you would consider, okay, well, we need higher levels than the goal troughs, which we are normally shooting for. But what is that goal? We could go off general AUC goals, which tend to be, a 200 nanogram per milliliter hour for the 12-hour interval. That would be the best data we have for what to shoot for.
Thanks, Rick. We'll now move on to questions for Anna. There's a couple here. How many of you are working in transplant in Spain?
Okay, thank you. Thank you, Syria, for that question. Well, in fact, we have carried out a national-wide survey to find out how many pharmacists there are in Spain working in transplantation, and in spring 2022. And there were 42 questions on different topics, 15 questions about the activities we do, and 4 questions about collaboration with the MDT, 6 questions about education and training to the patient and to the members of the MDT, 8 questions about teaching resident pharmacists of those from other centers, and a research question. And there were 34 responses from 23 hospitals and 12 regions from Spain. 85% were from hospitals with more than 500 beds. And most pharmacists work part-time in transplantation in Spain at the moment. And the activities they do the most are, at the moment, validation of pharmacological treatments and reconciliation at admission, in care transitions, and at discharge. But we think that in the future this is changing, and more pharmacists are going to work full-time in transplant in Spain. So this is our...
Thanks, Anna.
Thank you.
I'll hand you over to Heidi to take us out for the day. Thanks, everyone.
Yeah, and thank you to everyone for attending today. We appreciate it. Special thank you to our presenters and for the 3 great presentations, and to the ISHLT pharmacy community for organizing this session today. A poll will be sent out after this session, so please watch your inboxes for that. And then don't forget to sign up for upcoming webinars as well. I believe the next one is this Friday, January 20th, when the Research and Immunology Committee will be discussing future roles for next generation sequencing and heart and lung transplant diagnostics. So it should be a great session. I hope to see you guys all there. Thank you, guys.
Thanks, everyone.
Thank you.